Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care, so that you can make informed decisions, get peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered a question from one of our other readers, and the question last week was, my mom is in intensive care on a breathing tube. Is it the right thing for her to go to a long-term acute care facility? You can check out last week's question by clicking on the link below this video. In today's episode of Your Questions Answered, I want to focus on very important questions today. And today's episode is about what questions should you be asking if you have a loved one in intensive care. So today is really a very, very important episode here, because basically if you follow the instructions here in this video, or if you follow the instructions in the written version of the video blog below, you can literally get all the answers that you need when you have a loved one in intensive care. Now, some of it might need interpretation, but at least you have a good ground to stand on when you're dealing with intensive care teams, because it really sets you free asking the right questions, and the intensive care team will know that you're doing your own research, and it'll help you to make informed decisions, get peace of mind, real power, real control, and influence. So even if I do sound like a broken record, please keep in mind the biggest challenge for families in intensive care is that you simply don't know what you don't know. In today's video, however, I'm going to give you the most condensed form of everything you need to understand and you need to know when you have a loved one critically ill in intensive care, and what questions you need to ask. Intensive care, as you know by now, is such a highly specialized area, and it takes many years of training either as a doctor or as a critical care nurse to understand and master intensive care. You will see that asking the right questions in intensive care is like going down a rabbit hole. One question leads to the next. It's like a jigsaw puzzle. Miss one piece and the picture is incomplete. When families come to us here at Intensive Care Hotline, they are feeling lost. They are feeling challenged, outside of their comfort zone. They're feeling vulnerable, and they simply don't know what they don't know. Families in intensive care come to us and ask what questions they need to ask when their loved one is critically ill in intensive care. If it was only as simple as, yes, you do need to know what the right questions are when you have a loved one critically ill in intensive care and is fighting for their life. As a matter of fact, it's absolutely critical to know the right questions to ask and connect the right dots. Not knowing the right questions to ask could be the difference between life or death. And it's most certainly also the difference between you and your family being able to make informed decisions, get peace of mind, control, power, and influence. Knowing the right questions to ask when you have a loved one critically ill in intensive care, knowing what to look for, and knowing how to manage doctors and nurses in intensive care instead of the doctors and nurses managing you will make all the difference when you have a loved one critically ill in intensive care. The minute you start asking the right questions, you will get the right answers, and the dynamics will change in your favor. This is critical because you and your family are in a very challenging and once-in-a-lifetime situation that you know you can't afford to get wrong. Having said that, when families of critically ill patients in intensive care come to us, they do ask us what questions they need to ask. They're looking for the magic bullet and for all the right answers, and so they should. You will see that as we go along in today's video that there are dozens of very important and high stakes issues and things happening simultaneously at the bedside of your critically ill loved one, and each of those pieces fits in like a piece in a jigsaw puzzle. If you're missing one piece, the picture is either incomplete or the whole picture is falling apart. When someone is critically ill in intensive care, especially when ventilated and on other mechanisms of life support, there are dozens of very big and little important things happening simultaneously. All of those dozens of little and big things happening simultaneously are important, and if you don't understand those things happening simultaneously, you will have a very difficult time understanding what is happening. This is why intensive care is such a highly specialized area. It takes years of training and years of practice to master and understand. In today's video, I will help you understand so that you can learn and start speaking this quote-unquote secret intensive care language. Especially during times when you might be locked out of ICU because of a pandemic situation, i.e. currently the COVID-19, you need to be in a position to get to crucial and more or less life or death information very, very quickly. After having worked in intensive care for 20 years, where I looked after thousands of critically ill patients and their families, and where I also worked for over 5 years as a nurse unit manager in intensive care, I know how intensive care units operate. I also know how you as a family feel when disaster strikes and you have a loved one critically ill in intensive care. Intensive care teams are often vague in what they share with you and how transparent they are, because the stakes are often too high for them, just as much as the stakes are very high for you. Intensive care teams have their own agenda. They manage beds, staff, equipment, financial budgets, clinical research projects, and each piece of the puzzle makes its way in how they're dealing with families in intensive care. Once you know the exact clinical questions to ask, the intensive care team will know in a heartbeat that you are doing your research and that you are having resources available to you that help you understand intensive care and critical care and give you an unfair advantage. The dynamics will then shift in your favor, and you will have more leverage when dealing with and negotiating with intensive care teams. But keep in mind, this is just the start. In order to really understand treatment options, prognosis and diagnosis, more research and more in-depth conversations are needed. Without further ado, let's look at the things you need to ask when you have a loved one in intensive care. The questions I'll be sharing with you are structured from head to toe, just like medical and nursing professionals make their assessment, as well as handovers are done on critically ill patients in intensive care. Please note that whilst we look at the questions from head to toe, many of the questions can't be looked at in isolation and span across more than one section. Okay, let's start with the neurological condition when your loved one is in intensive care. Why is this important? Why do you start from head to toe? Well, first off, many, if not most patients in intensive care, their neurological condition is impaired because they're either in an induced coma or they're close to coming to an induced coma. They might be in a natural coma. So many patients in intensive care are either unconscious or semi-conscious. So let's start with the neurological condition and the assessment. So first question is, how awake is your critically ill loved one? Are they in a natural or in an induced coma? Are they conscious? What is their Glasgow Coma Scale or GCS score? The Glasgow Coma Scale is a commonly used neurological assessment tool to assess a patient's neurological status and condition. And I have put the Glasgow Coma Scale score assessment tool below this video in the written version of this blog, so you can have a look at it in more detail. Next, is your critically ill loved one in pain? If so, how is pain being managed? Also, if your loved one is semi-conscious or in an induced coma, a RAS score if you want to dig even deeper, especially when your loved one is in an induced coma. Furthermore, you want to 100% find out what pain medication your loved one is on. There can be a big difference in how pain is being managed and also how this impacts on your critically ill loved one's condition. For example, if your loved one is on opiates such as morphine or fentanyl, their level of consciousness or awareness is most likely limited, and their GCS or Glasgow Coma scale can be reduced because of it. If you're on light painkillers such as Panadol or anti-inflammatory pain medication, your loved one is most likely more awake, but those painkillers have other side effects, including liver or kidney failure. Overall, the devil is in the detail in intensive care, and you can see that as we go along in the questions you need to ask in order to make informed decisions, get peace of mind, control, power, and influence. Also, if your loved one is in intensive care with the following neurological conditions such as TBI or traumatic brain injury, subarachnoid hemorrhage, subdural hemorrhage, brain aneurysm, aneurysm coiling, stroke, seizures, hypoxic or anoxic brain injury, your questions should be focusing on the following issues. A. For any of the conditions that I just mentioned, you should be focusing if a CT scan or an MRI scan of the brain has been done to get more information about the condition of the brain. B. If your critically ill loved one is diagnosed with a TBI or traumatic brain injury or with a subarachnoid hemorrhage or subdural hemorrhage, they may have an intracranial pressure monitor in their brain. This is also known as an ICP, which is often attached to an EVD or external ventricular drainage. ICPs or intracranial pressures should be 5 to 15 mm per mercury or 7.5 to 20 centimeters per water. Any measurements outside of those parameters can cause irreversible brain damage. C. If your loved one has been admitted with a stroke, again ask if a CT or MRI scan of the brain has been done for diagnostics and prognosis. You should also want to find out if your loved one has had an ischemic or hemorrhagic stroke. There's a big difference there, mainly because the cause, but also because of ongoing treatment. So an ischemic stroke is a stroke where your loved one might have sustained a thrombus going to the brain, and a hemorrhagic stroke is a stroke where bleeding occurred. D. If your loved one has been admitted to intensive care with seizures, how are seizures being treated? What is their first line management, i.e. benzodiazepines such as diazepam, Valium, midazolam or Versed, or medications such as Keppra or phenytoin, Vimpat, sodium valproate, and the list goes on. As you can already see, asking questions about your critically ill loved one's condition in ICU is going down a rabbit hole. I'll talk more about induced coma under the respiratory or ventilation side of things. Technically, induced coma is a neurological issue. However, one of the main reasons for an induced coma is mechanical ventilation with a breathing tube or endotracheal tube. Hence the reference to the respiratory system further down in this video. So to quickly summarize, questions to ask as part of the neurological assessment. 1. Is your loved one awake and conscious? 2. What is their Glasgow Coma scale or GCS? Do they have a head or brain injury? Do they have a stroke or seizures? Is pain an issue? If yes, is it controlled? 6. If your loved one has a traumatic brain injury, a subarachnoid or subdural hemorrhage, do they have an ICP monitor or an EVD drainage? If yes to the last questions, are ICPs or intracranial pressures under control? If yes to question number 4, has a CT brain or MRI brain being done? And if a CT scan or an MRI scan of the brain has been done, what are the results? Next, if yes to question number 4, how is the stroke or seizure being managed? Is the airway stable? And last but not least, is your loved one on any sedation? If yes, what are those sedatives? How much are they giving? When is the last time sedatives have been given? So that's the neurological assessment. Let's move on to number 2, the cardiovascular system or the hemodynamic system, which is basically everything that includes the heart and the circulation of the blood and so forth. So let's look at this. So what is your loved one's heart rate and heart rhythm? A faster than normal heart rate might indicate pain, discomfort, but could also be a sign of infection and sepsis. If the heart rate is irregular, such as AF or atrial fibrillation, of it and how are they treating it? Often when the irregular heart rhythm is present, other complications might occur, such as an unstable low blood pressure that needs to be supported with life-supporting drugs such as inotropes or vasopressors. If your loved one is on inotropes or vasopressors, they are also on life support, as inotropes and vasopressors are considered life support. Common medications being used for inotropes and vasopressors are epinephrine, also known as adrenaline, norepinephrine, also known as Levophed or noradrenaline, dobutamine, dopamine, milrinone, vasopressin, to mention the most common inotropes and vasopressors used in intensive care. On the other side of the spectrum, sometimes your loved one can be hypertensive as well, meaning sustaining a high blood pressure, a high systolic blood pressure in particular, and it can be higher than 140 millimeter per mercury. If that is the case, it often needs medical management with vasodilators, which are the opposites of vasopressors and inotropes. Common vasodilators being used in ICU are GTN, SNP, given intravenously. You therefore also need to ask, what is your loved one's blood pressure? Is it sustainable with life? If it's not sustainable with life, that's when your loved one needs said inotropes and vasopressors. One of the main side effects of some unsatisfactory or low blood pressure is kidney or renal failure. If the blood pressure is low for prolonged periods, meaning systolic blood pressure is less than 90 millimeter per mercury and mean arterial pressure is less than 65 millimeter per mercury, for prolonged periods, the risk for kidney or renal failure is increased. It's one of the reasons why you see many patients in intensive care on dialysis machines. There are various ways how the cardiovascular system is being assessed and continuously monitored in intensive care, such as heart rate, blood pressure, temperature, and you will need to find out those parameters. The heart function is crucial, as nothing happens without a well-oiled and well-functioning heart. If there are any issues with the heart, such as heart attack, cardiac arrest, post-open heart surgery, etc., or heart failure, your critically ill loved one should have an ultrasound or echocardiogram of the heart, or a TOE, which is a transesophageal echocardiogram of the heart, to determine cardiac or heart function and to determine ejection fraction, or EF, which indicates the contractility or the pump function of the heart. This is an important indicator of cardiac or heart function, and also an important indicator if life-sustaining measures such as inotropes or vasopressors are required long-term or even in the short term. Long-term inotropes or vasopressors for a poor cardiac or hemodynamic function or because of severe sepsis are not an option, and irreversible cardiac failure or respiratory failures such as ARDS or cystic fibrosis may warrant ECMO treatment. We have numerous articles and case studies on our website about such issues and treatment options such as ECMO, cardiac failure, respiratory failure, ARDS, etc. Just use our search bar and type in your search terms and you will find articles and case studies about those issues. Other questions you need to focus on as part of the hemodynamic and cardiovascular system are: if your loved one has a central line, a CVC, and or arterial line. A central line or CVC is important to A, give certain drugs such as inotropes or vasopressors that couldn't be given via a normal peripheral IV line. Other medications that can only be given via central line or CVC are total parenteral nutrition, also known as TPN, potassium, certain antibiotics, 25% dextrose, and generally speaking drugs with a pH of less than 4 or greater than 9. Next, with the central line you can measure CVP or central venous pressure. The CVP indicates the fluid or volume status of a critically ill patient. It indicates dehydration versus fluid overload. A normal CVP is 2 to 6 mm per mercury. Via a central line you can also give fluids rapidly in emergency or semi-emergency situations such as blood products or hydrocolloids. If a long-term central line or CVC is required, a PIC line, which stands for peripherally inserted central catheter, is preferred. If certain clinical criteria are met, a Swan-Ganz or PA catheter is indicated. With a Swan-Ganz or PA catheter, more sophisticated clinical parameters can be obtained, such as cardiac output, cardiac index, again to determine heart functionality, such as contractility, which is also known as the pump function, fluid status, lung volume, and vascular resistance. Both Swan-Ganz or PA catheter and the central line also pose a high risk for infection. Other issues as part of the hemodynamic or cardiovascular system are daily and sometimes twice daily blood results. Blood results you should be focusing on are HB or hemoglobin, also known as red blood cells, white cell count, abbreviated as WCC, for signs of infection, CRP, inflammation or infection marker. Also electrolytes such as magnesium, potassium, calcium, phosphate and sodium. If potassium and magnesium are out of balance, this could cause irregular heart rhythms. Next, cardiac enzymes, also known as heart enzymes. Troponin for indication of a heart attack. Normal troponin levels are 0 to 0.4 nanogram per milliliter. CK levels 22 to 198 units per liter. Next, coagulation results. APTT, INR, and platelets. Coagulation results are important to look for how thin or how thick the blood is and how quickly it clots. This is important in intensive care because many patients are at risk of thrombosis. Next, liver enzymes, GLT, GGT, ALT, albumin, and bilirubin. Next, kidney or renal markers, urea, creatinine, GFR, or BUN levels. You can find more general information about blood and pathology results in intensive care on another section on our website, and I put a link to that section below this video in the written version of this video blog. Furthermore, if your critically ill loved one has ongoing bleeding or is anemic because of other medical conditions and hemoglobin is low, your loved one might need a blood transfusion in the form of red blood cells. Normally, the threshold for requiring a blood transfusion is at 6 gram per liter or 7 gram per liter, 60 gram per deciliter or 70 gram per deciliter. Especially in light of the fact that low hemoglobin can cause hypotension, which is low blood pressure, and therefore inotrope or vasopressor use. One way to reduce inotrope or vasopressor use is to give blood products if hemoglobin is low. Other blood products that can be given are FFPs, fresh frozen plasma, platelets, or albumin. Also, part of the cardiovascular system is the administration of anticoagulation. Part of the is the administration of anticoagulation drugs, and such as or blood thinners. Anticoagulation bloods are also known as blood thinners, such as heparin, fragmin, enoxaparin, clexane, to name a few. When being critically ill and immobile, or at the very least being restricted with mobility, anticoagulants, also known as blood thinners, need to be given to prevent deep vein thrombosis, also known as DVT. If anticoagulation is contraindicated, at the very least, TED stockings or calf compressors need to be worn to keep the blood circulating and again to prevent DVTs which are also known again as blood clots. The risk of a deep vein thrombosis is real in ICU without anticoagulation, TED stockings or calf compressors. Commonly used anticoagulation blood drugs or blood thinners are enoxaparin, clexane, fragmin, heparin, warfarin, Plavix, clopidogrel. Also, when we consult families in intensive care one-on-one, we ask them to send us pictures of the bedside monitor so we can ascertain quickly the hemodynamic status of their loved ones. To summarize, questions to ask as far as the cardiovascular and hemodynamic system in intensive care for your loved one is concerned. Number 1, what are your loved one's vital signs, i.e. heart rate, heart rhythm, blood pressure, oxygen saturation, temperature? Number 2, is your loved one on inotropes, vasopressors or vasodilators? Again, inotropes, vasopressors or vasodilators are considered life support. Number 3, what are the blood results as per the list that I mentioned before? Number 4, does your loved one have a central line or a CVC? Number 5, is your loved one receiving any blood products or blood transfusions? Number 6, is your loved one's heart function a concern? Number 7, if yes to the previous question, has the heart been formally checked with an ultrasound or a TOE, also known as transesophageal echocardiogram? Number 8, if yes to questions 6 and 7, what is your loved one's ejection fraction or EF? If yes to question number 6, do they have a Swan Ganz or PA catheter to measure cardiac output and cardiac index? Number 10, is your loved one on anticoagulation or blood thinning medications? If no, are they wearing TED stockings or are they attached to calf compressors? Number 11, have sputum samples, urine samples and or blood samples been done to look for sources of infections? Okay, now let's look at the respiratory system or at the breathing. So we have moved from the head to the heart and now we're looking at the lungs as we work our way downwards. Many patients when going into intensive care need the support of their respiratory system because of their inability to breathe. The following is applicable when patients go into intensive care as far as the respiratory status is concerned. A. Breathing spontaneously on room air or 21% oxygen. B. Breathing spontaneously with oxygen support either via nasal cannula or via an oxygen mask. C. Breathing spontaneously with high-flow nasal oxygen via nasal cannula. D. Breathing with a ventilation mask either via BiPAP or CPAP. E. Breathing with a breathing tube or endotracheal tube attached to a ventilator. This mode of ventilation often goes hand in hand with sedation and an induced coma. F. Breathing with a tracheostomy attached to a ventilator. G. Breathing spontaneously with a tracheostomy with either humidified oxygen via tracheostomy shield or humidified air with tracheostomy shield. H. Breathing via tracheostomy may also be a combination of being on and off the ventilator. Next, if your loved one is attached to a ventilator with a breathing tube or endotracheal tube or tracheostomy tube, they will also need frequent suctioning or airway clearance because of their often limited ability to cough and clear secretions and the unstable airway. The frequency as well as the amounts of secretions needing to be cleared is one of the indicators if a breathing tube or endotracheal tube can be removed or not. The same is applicable for the tracheostomy tube. The frequency as well as the amounts of secretions needing to be cleared is one of the indicators if a tracheostomy can be removed or not. Next, if your critically ill loved one needs ventilation support in either of the forms I mentioned before, they will most likely need an arterial line at least temporarily. An arterial line has the ability to check the effectiveness of ventilation or oxygen support by checking oxygen and carbon dioxide levels in the arteries in the blood. An arterial blood gas can give many other blood results as well, but for the purpose of this section, we just want to keep focusing on what is important for now. So, what is important for now from a ventilation point of view? So let's look at normal arterial blood gas levels. pH 7.35 to 7.45. PaO2 or partial pressure of oxygen 75 to 100 mm per mercury. Partial pressure of carbon dioxide or PaCO2 35 to 45 mm per mercury. Bicarbonate 22 to 26. Oxygen saturation or O2 sats 94 to 100%. Lactate 0.5 to 1 millimole per liter. Irrespective of whether your critically ill loved one is breathing spontaneously or on a ventilator, the arterial blood gas results will give you a very good indication of how effective ventilation support is. You should also be asking for ventilation modes when on the ventilator, as it will indicate how far away from getting off the ventilator your loved one is. There are several different ventilation modes when on a ventilator, and once again, the devil is in the detail when it comes to ventilation forms and ventilation modes. Also, if your loved one is in an induced coma and on sedation because of mechanical ventilation and the breathing tube or endotracheal tube, your critically ill loved one will be unconscious until they can either be extubated, which is the removal of the breathing tube or the removal of the endotracheal tube, or until a tracheostomy can be performed. An induced coma requires sedation and opiates. Commonly used sedatives in intensive care are propofol, also known as Diprivan, or midazolam, also known as Versed. Commonly used opiates or pain relief in intensive care are fentanyl or morphine. Other sedatives combining pain relief and sedation is dexmedetomidine or Precedex. Sometimes clonidine is also used for sedation. Now, with clonidine and Precedex are almost the same because there's clonidine in Precedex, and sometimes clonidine or Precedex can also be used to manage withdrawal from addictive substances such as alcohol, but also addictive substances such as benzodiazepines or even morphine and fentanyl. Other issues that may come up whilst in an induced coma are issues that sometimes muscle relaxants or paralyzing agents are given because of ventilation issues, or to enhance patient ventilator synchrony, enhance gas exchange, and diminish the risk of barotrauma or pneumothorax. They can also be employed to reduce muscle oxygen consumption to prevent unwanted movements in patients with increased intracranial pressures and to facilitate treatment of acute neurological conditions. If your critically ill loved one is in ICU with breathing problems, they should have physiotherapy or physical therapy to improve their breathing. This is also commonly known as chest physio. Early mobilization does also help with respiratory or breathing issues. Hence, the sooner your loved one gets out of bed, the higher the chances that their breathing and spontaneous breathing efforts will improve. It's also very important to have a basic understanding of ventilation modes in intensive care. There are many ventilation forms and modes in intensive care that indicate varying degrees of controlled ventilation, spontaneous ventilation, or a combination of controlled and spontaneous ventilation. Those ventilation forms are important to ascertain how far away your critically ill loved one is from getting extubated or being weaned off the ventilator and the tracheostomy. Again, when we consult families in intensive care one-on-one, we often ask them to take a picture of the ventilator so we can ascertain quickly how far away their loved one is from being weaned off the ventilator or how far away they are from extubation. Let's summarize the questions to ask about ventilation and the respiratory system. Number 1, is your loved one breathing spontaneously or with a machine? Number 2, do they need oxygen? Number 3, is breathing without a ventilator If breathing without a ventilator is breathing adequate, is your loved one at risk of needing a ventilator? Number 4, what are the latest chest X-ray results? Your loved one should have daily chest X-rays whilst being ventilated in ICU. What are the latest arterial blood gas results? Number 6, if your loved one is on ventilation with a mask, BiPAP or CPAP, is it effective? Can ventilation with a breathing tube be avoided because of it? Number 7, if your loved one is ventilated with a breathing tube or endotracheal tube, how far away are they from getting extubated, which is the removal of a breathing tube? Number 8, if they are not ready for extubation, what are the next steps? Do they need a tracheostomy? Number 9, if they're having a tracheostomy, how far away are they from weaning off the ventilator and the tracheostomy? And number 10, if your loved one is ventilated with a breathing tube or endotracheal tube or tracheostomy, how often do they need suctioning or airway clearance? Let's move on to the next section, which is the gastrointestinal tract or GI system, and let's look at bowel movements, nutrition, and so forth. The next question you need to ask are in relation to the GI or gastrointestinal system. When your loved one is critically ill in intensive care, nutrition is often altered because of the inability to take in food and hydration orally. The need for nutrition and hydration is still there, however. There is the old joke amongst ICU nurses and ICU doctors that as soon as a patient starts to eat and drink orally, they're on their way out of intensive care. The minute they start complaining about the food, they will need to leave intensive care immediately. Putting jokes aside, the reality is that as soon as your loved one is in intensive care needing mechanical ventilation with a breathing tube or an endotracheal tube and intubation, they also need a nasogastric tube. The nasogastric tube is inserted through the nose and is sitting in the stomach. The nasogastric tube can be used for feeding or also for drainage from the stomach if there are issues with reflux, for example. It can also be used to check if food is being digested and absorbed. A nasogastric tube should be temporary and should be removed when a patient can breathe independently, is awake and alert, as well as able to swallow safely. If, for example, a tracheostomy is needed, often discussions are being held with families to change from the nasogastric tube to a PEG feeding tube as well. A PEG feeding tube has a permanency to it which we think is counterproductive for trying to wean patients off ventilation and tracheostomy, and it may foster complacency. Again, this is where we can help you to make the right decisions for your loved one so they can have the best chance for the best care and treatment with the best outcomes. Next, sometimes food cannot be absorbed when patients are in ICU, or other gastrointestinal issues may prevent your loved one from having nasogastric or PEG feeds. If that's the case, then the alternative is to use TPN or total parenteral nutrition via central line or PICC line. TPN is also known as intravenous or IV nutrition. Next, when your loved one is critically ill in intensive care, mobility is automatically decreased and therefore the peristaltic of the bowels is reduced. Therefore, bowel motions and bowel movements are decreased. This is specifically important during an induced coma because, again, the sedative and opiate drugs reduce bowel peristaltic and bowel motions. Hence, it is important to manage bowel motions with aperients and laxatives so that regular bowel motions can be maintained. It's also important to avoid bowel obstructions because, again, the risk is increased for a bowel obstruction to occur while in ICU for the reasons that I just mentioned. To summarize, questions to ask about the gastrointestinal section. Number 1, is your loved one eating or drinking orally? Number 2, if not, do they have a nasogastric tube and are they being fed via the nasogastric tube? Number 3, is your loved one absorbing their feed? Number 4, is your loved one opening their bowels? Number 5, is your loved one having stomach protective medicine such as pantoprazole, also known as Somac, ranitidine, also known as Zantac, esomeprazole, which are also known as PPIs or proton pump inhibitors. This is to avoid stomach ulcers and stomach or GI bleeds due to stress-induced ulcers whilst being critically ill in intensive care. Because stress in intensive care is increased, stomach ulcers are more likely, and therefore stomach bleeds are more likely. Now, therefore, early feeding in intensive care is very important. If it's not orally, early feeding needs to start with a nasogastric tube. Let's look at number 5, at the renal or kidney functions. The kidneys have a special role to play when your loved one is in intensive care. If the kidneys are working throughout your loved one's stay in intensive care, that's great, tick the box and don't worry about it. But inevitably you will need to ask if the kidneys are working, because often kidney function is impaired when patients are critically ill in intensive care. If the kidneys aren't working, your critically ill loved one could be in trouble because of urine output is impaired. If urine output is impaired, issues such as fluid overload come up, and those issues may manifest itself with pulmonary edema or fluids in the lungs. This could be detrimental when weaning off a ventilator or when trying to avoid mechanical ventilation and the breathing tube in the first place. If kidney function is not an issue to begin with and not part of your critically ill loved one's condition, chances are that it may become an issue throughout your loved one's journey in intensive care. Why? Why could kidney function become an issue whilst your loved one is critically ill in intensive care? The first thing you need to understand about the kidneys is that they're highly sensitive and highly susceptible to sustained low blood pressure. As you would have seen under section 2, cardiovascular or hemodynamic system, low blood pressure is a regular occurrence for critically ill patients in intensive care. The longer critically ill patients go without sufficient or adequate blood supply to the kidneys, the higher the risk for the kidneys being damaged or, quote unquote, taking a hit. The first sign of the kidneys being impaired is usually low urine output. As a rule of thumb, normal or physiological urine output should be between 30 to 80 mils per hour. Anything less than 30 mils per hour for a few hours raises alarm bells in intensive care, and it usually needs investigations and or medical management. Daily fluid balances in intensive care are normal, where fluid input and fluid output are calculated at midnight. The fluid balance, as well as hourly checks and documentation of urine output and fluid intake, are critical to keeping the fluid balance in check, quite literally. Hourly checks of urine output can be done with an indwelling urinary catheter. Most critically ill patients in intensive care have a temporary indwelling catheter inserted into their bladder. If fluid balances are too positive, i.e. higher fluid input than urine output, pulmonary edema might be one of the signs, plus peripheral edema or fluid swelling might be visible in hands, feet, belly, etc. Next, blood tests such as urea creatinine, GFR and BUN levels are also indicators for kidney or renal impairment. The first-line treatment for low urine output is usually diuretics such as Lasix or furosemide. Sometimes spironolactone is also being used as a potassium-saving diuretic. If the cause of low urine output is dehydration, then a fluid challenge might be indicated. If the cause of the kidney failure is simply that the kidneys are failing, then hemodialysis or hemofiltration is the next step. Here, the dialysis machine, also known as CRRT or continuous renal replacement therapy, is taking over the function of the kidneys and is removing fluids and other toxins that normally would be cleared by the kidneys. Over time, the kidneys may recover with dialysis, but it's not guaranteed. In the short term, dialysis is the best option to deal with failing kidneys. Daily checks of urea, creatinine, BUN and GFR levels in the blood are necessary to keep an eye on kidney function. Another sign of dehydration versus fluid overload, besides checking urine output hourly, are sodium levels. High sodium levels indicate dehydration and low sodium levels indicate potential fluid overload. Again, as you can see, the devil is absolutely in the detail. So, questions to ask about the kidneys are: number 1, what is the fluid balance? Number 2, what is the hourly urine output? Number 3, what are sodium levels? Number 4, get urea, creatinine, BUN, and GFR levels. Number 5, if your loved one is on hemofiltration or hemodialysis, how many mils per hour are being removed? Number 6, electrolyte levels such as potassium and magnesium. High volumes of fluid removal, either via drug-induced diuretics such as Lasix, furosemide, or via hemofiltration or hemodialysis, can reduce potassium and magnesium levels to a point where the heart or cardiac function can be impaired. On the other hand, when the kidneys are failing, potassium is elevating and again can cause heart or cardiac disturbances, can cause a cardiac arrest as a worst case scenario. Let's go down our list and let's next look at the endocrine system, which is also part of blood sugar regulation. The endocrine system in intensive care can be important in some, but not in all situations. We are just covering the basics here of the endocrine system and we won't go into too much detail. Most other aspects of intensive care are more important in most cases. Many non-diabetic patients in intensive care can become temporarily hyperglycemic, meaning they can have a high blood sugar temporarily. This is a side effect of critical illness and stress response. High blood sugars in intensive care can be treated with a temporary administration of insulin intravenously or also subcutaneously. If your loved one in intensive care has a pre-medical history of diabetes, their blood sugars are most likely to be higher than usual, and again higher doses of insulin are needed. If your loved one is diabetic and wasn't on insulin before the ICU admission, they most likely will be needing insulin now. In most cases, insulin can be ceased eventually. Just know that blood sugars are likely to go up during the critical illness in intensive care. They can also increase sometimes secondary to certain medications being used in intensive care, such as steroids, such as hydrocortisone, dexamethasone, methylprednisolone, to name a few. Questions to ask about the endocrine system. Number 1, is your loved one's blood sugar within normal levels? Number 2, if the blood sugar is high, is your loved one on insulin? Number 3, do they think that high blood sugar is a stress response secondary to the critical illness or drug-induced from steroid use? Other issues with the endocrine system can be pancreas issues, but again, that is a specialized subject altogether, so we won't go into that in this video. Let's look at number 7. Let's look at the general aspects of being a patient in intensive care. This is also very important and often a neglected aspect of your loved one being critically ill in intensive care. Here I'm basically talking more about the nursing care aspects when patients are critically ill in intensive care. Nothing is happening without excellent ICU nursing care. Here is a list of the things that are part of excellent nursing care in ICU. You will need to ask for those things. Number 1, daily bed bath, including regular backwashes when patients change position to freshen them up, as well as getting the blood circulation going when being immobile. Number 2, regular mouth care, eye care, and nose care at least 6 hourly when in an induced coma, twice daily, and as per patient request when awake and not in an induced coma. Number 3, regular pressure area care, changing position every 2 to 3 hours in order to prevent skin breakdown and pressure sores. Number 4, mobilization. As soon as your critically ill loved one can get mobilized in a chair and out of bed, it needs to happen. Early mobilization is saving lives and it helps weaning patients off ventilation. If ICUs are not mobilizing patients, it's complacency and not lack of resources. There are situations where patients in intensive care can't be mobilized, such as on ECMO, ARDS, trauma patients, if patients are on neuromuscular blockers, in induced comas, etc. But there are plenty of patients that can be mobilized even on ventilation with a breathing tube and a tracheostomy. Number 5, especially for patients on ventilation with either a breathing tube or endotracheal tube or tracheostomy, they will also need to have chest physiotherapy or physical therapy. This will help with ventilation weaning, and I highlighted that earlier in the ventilation or respiratory section. Number 6, quality ICUs will also offer patients a shower in a shower trolley when necessary, especially for long-term ICU patients, including for patients on ventilation. Or as soon as a patient can get mobilized, sit in a chair, they should also have the opportunity to have a shower, as long as they are hemodynamically stable. Having a shower works wonders for patients in intensive care. The positive effect it has cannot be underestimated. In closing now, that you have read or gone through this video, this list of explanations and questions, you know and understand why I always say that the biggest challenge for families in intensive care is that you don't know what you don't know. This has been a very comprehensive list of questions for families in intensive care, but it doesn't stop there. It's like going down a rabbit hole. Once you're in there, you can't stop. I could have gone into even more detail, but for now, if you ask those questions to begin with, the intensive care team will inevitably and immediately know that you are talking to someone who understands intensive care inside out. This is the first step for you in making informed decisions, get peace of mind, control, power, and influence. The intensive care team will look at you differently, and you will be a 1%er, as opposed to the 99% of families of critically ill patients in intensive care who will never know what to look for, what to ask, and therefore they don't know what they don't know, because they either trust intensive care teams blindly or they don't do their own research. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power, and influence quickly, whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision-making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report will give you in-depth insight that you must know whilst your loved one is critically ill in intensive care or is even dying. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care, and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also have a look at our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site, intensivecaresupport.org, for families of critically ill patients in intensive care. You can also call me, find phone numbers on the top of the website. Also, have a look at our ebook section, and you can get one-on-one consulting and advocacy with me over the phone via Skype and via email by clicking on the relevant tabs on the top of the website. This is Patrick Hutzel from intensivecarehotline.com, and I'll talk to you in a few days.